Support for this podcast comes from iTube.net. iTube is ophthalmology's leading source for high quality ophthalmic surgical videos, educational series, spotlights, and more. Visit iTube.net or follow us on Instagram at iTubeNet.
You're listening to
CRST
podcast
from Bryn Mawr Communications.
Welcome to CRST, the podcast. I'm Uday Devgan, your guest host today. Today you're going to hear from Christopher Starr and Brian Schaefer in two short segments, building off their contributions to CRST's October 2025 cover focus, which was titled Refractive Cataract Roundtables. So let's get started here. Now, first up, we've got my good friend, Dr. Christopher Starr from Weill Cornell Medicine there in New York City on pre-op ocular surface optimizing prior to, let's say, doing cataract surgery or even refractive corneal surgery. So, Chris, thanks for joining.
Thank you. Thanks for having me.
Now, to set the stage, what problems are we actually solving when we say we optimize the ocular surface before measurements?
Yeah, as you know, as a high-volume refractive cataract surgeon, the outcomes are so critical, and expectations of patients have never, ever been higher in our field, right? The perfection is the only possible outcome, and if it's slightly imperfect, we got problems. So, the refraction and refractive outcomes start with the ocular surface and the tear film, as you know, and optimizing the ocular surface is critical for not only precision when it comes to our pre-surgical measurements, our IOL calculations and Ks and all of those formulas, but also for vision after. We know that surgery will affect the ocular surface. We know that usually dry eye will worsen after cataract surgery. Any incisional surgery, whether it's corneal, cataract, refractive, it all takes a toll on the ocular surface. And so even if the ocular surface is optimized prior to surgery, we can have problems after surgery with quality of vision, with, we always say there's quantity of vision and there's quality of vision. There's Snellen acuity, which is quantity, and then there's, of course, the quality of vision, which we don't necessarily have good ways to measure, but we certainly hear it when our patients complain. With the whole that whole like, oh, you're 20/20, congratulations, and the patient's like, well, yeah, I can read 20/20, but that's
right.
not good. What happened? And that's the quality of vision, and that. The ocular surface is critical for optimizing quality of vision too. And so I think that it's both preoperatively, intraoperatively, and postoperatively, we've got to pay, better attention to the.
Right. We spend so much time sweating the lens calculations and not remembering that the first thing that actually focuses light is the tear film, the ocular surface, right? And
That's
the patients
right.
do say that. They say, I know the vision's 20/20, but when's it going to be clear?
Exactly. Right. Yeah. And that's the kind of bugaboo when it with multi is extended depth of focus, but also LASIK and PRK and SMILE and there's that classic kind of disconnect between what we see on the Snellen chart and what patients convey to us about action. And in this era, all satisfaction and precision outcomes are so critically important that, and if you fail to recognize ocular surface dysfunction prior to surgery, then you're going to have a big headache on your hand, afterwards.
Sure.
And so
now you have a very good pearl for pre-op examination, which I liked. I've stolen this already. Look, lift, push, pull. Explain this to our listeners. This is a great one. Again, it's look, lift, push, pull.
Look, yes, exactly. It's the standardized, quick, and homogenized, standardized way to examine the ocular surface, not only for surgeons, anybody who sees dry eye patients. You look, lift, pull, push. You're looking at the ocular surface. You're looking at the tear film. You're looking at the lid margin. You pull up the upper lid because, as you know, there's a lot of pathology that can exist on the superior conjunctiva, which you will miss if you don't lift up that lid. So lift up, pull, meaning assess. Pull. Floppy eyelid syndrome is something that is very often missed and underdiagnosed and can lead to a lot of these problems with IOL calculations and satisfaction. And then push. What does that mean? You're pushing on the meibomian glands. It's the most fundamental, simplest thing that we can do to assess for dry eye disease and MGD. And you can look at the lid margin and miss MGD 80% of the time if you don't push on the glands to see not only, if anything's coming out, but if meibum is coming out, is it thick, is it like olive oil, or is it like toothpaste? And simple push. You don't have to push on all of the glands. You just push on a couple and see what's happening. We know that MGD is up to 86% of patients, have cataract age, and some studies even higher. And so it's very easily missed. And pushing on the glands tells you almost everything you need to know. Certainly more important than meibography or any of the more esoteric tests. Just pushing on those glands, I can't recommend it enough. Not only in the surgical patients, but all patients, who have dry eye.
Now, what's your threshold for what's acceptable in terms of ocular surface to proceed with cataract surgery? Because I'll argue with you that every 80-year-old has a not so hot ocular surface.
Yeah, and I think it's very independent based on who's sitting in, who's in front of you, as far, the patient, who that patient is, what their expectations are, which IOL they're having, how, and actually we created in our Ascaris algorithm, which we published about 6 years ago, and we're working on the next iteration of it. There is a questionnaire that we created, and in that questionnaire, it asks a lot of the ocular surface questions, but it also has some IOL questions that was taken from Steve Dell's IOL questionnaire about refractive IOLs, premium lenses, and there's a question in there that we took straight from Steve's questionnaire about personality type. Are you on a sort of on an analog scale? Are you super high maintenance over here, or are you easygoing and laid back over here? And then the patient will click who they are. So if you have somebody who's way over here, as a perfectionist, high maintenance person, I think your threshold, for optimizing that surface prior to surgery is going to be much higher, and it may even include delaying surgery if you're having a lot of variability in your IOL calculations, in your Ks. If the topography is changing from visit to visit, then I think your threshold is going to be higher at rescheduling that patient and optimizing the surface. Whereas if you have somebody on the other spectrum, they're like, hey, I plan to wear glasses afterwards. I'm pretty easygoing. I don't want to, pay money for a premium lens or a femto. And in that person, I think the threshold is lower. Now, things like Demodex, where if you see Demodex, and again, this is that whole look at the lid margin. If you see collarettes, if you see Demodex, we do know that there is a high rate of bacterial overload when there's Demodex present. So gram-positive bacteria will be at much higher numbers on the lid margin when Demodex is present. So I would behoove everybody, if you see Demodex, treat it, before surgery, because now we're talking endophthalmitis risk. Clean up those lashes, maybe do an antibiotic. Lotilaner is great, for cleaning up collarettes. BlephX procedures, all of the above should be utilized. But if the patient, doesn't have Demodex and they're low expectations and they're doing a standard lens and they plan to wear glasses, then I think the bar and the threshold is much lower. It all really depends on the patient.
Now, we all know that the corneal power kind of varies with the IOL power 1-to-1, right? So a
Yeah.
diopter change of the cornea is going to be equivalent to a Doppler change in your lens calcs. So obviously it's important. So if you have a patient and you see the biometry is not so great, topography is a little bit irregular, you treat their ocular surface, you clean them all up, you come back, you remeasure them. My two questions are, well, number one, how much can it change from the crummy pre-op to now the good pre-op measurements? And then how do you know when it's stable? Do you need to do a third measurement and make sure there's no more change?
Yeah, that's a good question. So, and as far as how much can it change, dramatic. It can be very dramatic. You can go from, a T to a non-toric IOL in 2 weeks, depending on the astigmatism and the axis and the magnitude of the astigmatism. Similarly, IOL, powers, since we're held to the standard of, quarter diopter perfection, that can change dramatically too from visit to visit. As far as kind of, in an ideal world, if you're optimizing the surface and the patient comes back and the topography looks good, and the Ks are consistent among, let's say, the IOL master or whatever biometer you use, the topography, as long as they're consistent amongst 2 or 3 measurements from different modalities on the same day, I think most of us would feel comfortable proceeding with that. In an ideal world, though, sure, you come back, have the patient come back yet again in another 2 weeks to see if it's consistent. But that's not practical in day-to-day practice. We're all busy. We all have lots of patients. We're all doing high volume stuff, and to have patients come back multiple times to ensure that the measurements are stable is just unrealistic. But I think once you feel like the surface is optimized, you do your slit lamp exam. You don't see corneal staining. I would say of all the metrics, corneal staining is probably the most important, especially when the PE central. But even peripheral PEs can have an impact, and of course, epithelial dystrophies, can certainly cause lots of variations in the measurements. But I think if you have the patient come back, you look at the surface, and you're like, yeah, it looks pretty darn good. There's no staining. The central cornea is smooth. You have an IOL master with Ks. You have maybe an auto keratometer that has Ks, and you have a topography that has Ks. And if they're all pretty close as far as the magnitude and the axis, I think you're good. I think you're good at that point. And whatever treatment you started prior to surgery to get the surface optimized, the patient should know that this can get worse afterwards, and we're going to keep these treatments going. And we may have to actually increase the treatment afterwards if it worsens to a point that affects your visual outcome. And so, I think education and explaining to the patients why you're doing all these things, and some of these things do have out-of-pocket costs, with LipiFlow or IPL or whatever, tear care, whatever it may be. But as long as the patient knows this is to improve your lifetime of having this lens in your eye for the rest of your life, we want to do everything we can to optimize your long-term outcomes by doing all of this stuff prior. And most patients are perfectly happy to, especially those ones that are like, I'm high maintenance perfectionist, I want everything done. But nobody's going to complain about cost or time, and even surgical delays if it means their outcomes are going to be improved.
Now, the challenge you were mentioning is also in the post-op period. So the patient, you saw them first visit, they were not optimized. So you do a whole month of treatment. They are like very religious about it. They're good patients. They come back, everything's perfect. You do a beautiful surgery, and now you got to tell the patient, by the way, you need to keep doing that the rest of your life. It's like, you better put this into your schedule.
Yeah, I usually say, this is, it's not, because people ask that question all the time. Do I have to do this forever? And I always say, no. I say, but for now, we need to do this and maybe a few things all at once because of the ocular surface dysfunction is at a high level. And I said, but our goal with treatment is to get you ideally off treatment at some point, but on a minimum of daily intervention. It could be 1 drop a day or 2 drops a day to maintain, satisfaction and to maintain vision and comfort. And so I never say, this is forever, even though for some people it actually is. But always try to minimize treatment with surgical and non-surgical patients. The goal is minimum intervention. I see a lot of patients in referral and second, third opinions who are like on 100 things, and they're not sure what's working, what isn't working, but obviously they're seeing me, so they're still unhappy. And usually my first instinct is let's stop all of that and let's start fresh, and let's start with incremental changes over time. And the goal is always minimum intervention to maintain the comfort and vision.
That's fantastic. Well, I do appreciate you spending the time with us here to talk about this. It is a topic that is actually far more important than sometimes we give it credit for.
Yeah.
And we talked about good pre-op examination, things to do in the post-op period, and kind of how to set those appropriate patient expectations. So again, thank you so much, Chris. I really appreciate it.
My pleasure, Uday. Always good to see you.
Up next, we have Brian Schaefer on IOL selection and counseling. Now, up next in our podcast, we have Brian Schaefer, who's going to talk to us about his IOL decision tree. So, Brian, welcome to the podcast.
Thank you, Uday. I appreciate it.
Now, there's so many different choices now for patients, for surgeons to offer to patients of different IOL choices, a whole spectrum. How do we make sense of it? How do we explain it to patients in an easy way?
It is a complex landscape that gets harder by the day as our armamentarium increases. But that's what makes it fun for us. The way that I do it in my practice is to keep it as simple as possible. When I see a patient for cataract evaluation, I sit them down, I pull out the model eye with every single patient, and I show them, you have a cataract. It's when the lens inside the eye becomes cloudy. Cataract surgery is when we numb up your eye, remove that lens, and replace it with a clear plastic one. At the time of surgery, we have the opportunity to do things one of two ways. Option one is standard, option two is customized. Standard is where we use the insurance issued lens, lets you see a lot more clearly, but you can still expect to wear glasses full time afterwards. Option two is customized, where you and I go on a journey to figure out how do you really want to use your eyes, with or without glasses, and depending on your visual goals, I'll choose a lens that makes the most sense for you. When I present it as such, it keeps it simple because there's really only two options. Do you want the standard or do you want an upgrade? And at that point in time, they're not paying for a specific piece of technology. They're paying for me to be their matchmaker. And once I give them my matchmaking services, that's the upgrade there. Whatever the cost of goods are, the cost of goods are. But really, my goal for them is to put them in the visual state that they truly desire. So once I've given them that spiel, if they're interested in customized, I sit back and I start asking them questions. What do you like to do? How do you spend your time? I'm also paying close attention while I'm in the exam room, showing them that model eye. I'm paying very close attention to how they're looking at it. Are they lifting their glasses off to see it up close? Are they putting their readers on to see it up close? Are they kind of just winging it, even though I know they're a +3 hyperope and there's no way they can see this in great detail, but they're still just looking at it without glasses? So that really helps guide me to figure out what is best for that patient. And I use this decision tree as a loose guide to really start to put the patient into different boxes.
So do you split then versus, let's say, range of vision versus absolute image quality and contrast? Is that a decision point?
That is totally a decision point where I'm deciding how scrutinizing is this patient in terms of their quality of vision versus how motivated is this patient to truly just be out of glasses. It's different for everybody. Everyone's just different. It's amazing how different every human is in what their true desires are.
Now, how do you set a reasonable expectation? Because a lot of patients will see, I'm in Beverly Hills. I got a very high expectation patients. But how do you explain to them that there are limits to our technologies here?
When they tell me that they're interested in customized, the first thing that I let them know right away is, unfortunately, there is no perfect technology. If there was, we would use it on everybody. There's nothing I can do to dial back the clock and make you a 14-year-old person who has absolute perfect vision. It just doesn't exist right now. My goal is to get you as close to your goal as possible. There will be some limitations and trade-offs with any of the technologies, and when I decide which one I think is best for you, I'll let you know exactly what those trade-offs are.
That makes a lot of sense. So you don't have to burden the patient with the whole concept of, do you want EDOF or monofocal plus or diffractive, refractive, trifocal, multiple? You don't even get into all that.
Totally. It's hard enough for our ophthalmology colleagues to keep them all straight. It's impossible to expect a patient to understand what the heck we're talking about in a couple minute conversation. So instead, I really do just as I said, where I just act as a matchmaker for them. And once I feel I've settled on the best technology for them, I explain that piece of technology, the pros and the cons, the drawbacks and limitations. And if I see that they're starting to squirm a little bit, that look in the patient's eyes where they're just not so confident that what you're saying is going to work best for them. When I see that moment, then maybe I will backpedal a little bit and present a different piece of technology. It doesn't happen that often, but it does happen occasionally. Typically, though, what I'm trying to understand first and foremost is how scrutinizing the patient's going to be with image quality. Because if they're scrutinizing with image quality, I prioritize that and it pushes them onto the side of my decision tree where I go to say, I really think that in order to give you what you're desiring, we're going to have to still rely on glasses some of the time. The reason for that is because there's no such thing as free light when it comes to optics. And if we want to make sure you're seeing your absolute best, we don't want to split up that light. And in order to do that, we use a lens that focuses all of the light to a single place on your retina. Now, in that conversation, depending on the patient's visual goals, how well they dilate, if they're post-refractive, I may be leaning towards just doing a toric lens, or I have 3 different places that are a straight shot to the light adjustable lens for me, and that's for patients who are post-refractive. Almost all post-refractive, with the exception of post-hyperopic LASIK, these patients with a lot of negative spherical aberration from a hyperprolate cornea. For most myopic LASIK patients, I choose the light adjustable lens if amenable. The other place that I use it a lot is what I call on my decision tree particular. And I say that in quotes because it's a positive description of a person who is type A plus. And I imagine you've got quite a few of them out in Beverly Hills. I've got them in Philadelphia. We take care of a lot of professors and engineers and architects, and they're very scrutinizing. And splitting light on them is not always the best thing.
So are there specific red flags you have then for certain patients? What are the kind of red flags like, hey, don't do a light splitting lens on this patient?
It's funny, there are quite a few of them. The first is if they come with a list of 10 questions. The second is their occupation, because I do ask all of them that. And it is actually pretty remarkable how consistent people who are engineers for an entire career, they really do have to be particular. They have to have extremely detailed perceptions of everything that they're doing in order to not make mistakes, because they're building houses and they're doing things that small tactical errors can lead to big errors. So they're very scrutinizing. The other thing that I always pay attention to is simply the patient's demeanor while I'm talking to them. If they're very high strung, they're noticing little subtleties in our conversation, that's somebody who's paying a lot of attention and might pay attention to their visual quality postoperatively.
Right. No, it makes a lot of sense. Now, are there clinical situations like you where you wouldn't put in a diffractive type of lens, like patient anatomy issues, corneal issues, retinal issues, things of that nature?
Yeah, specifically for diffractive, I am pretty selective. The way that I kind of approach this whole thing is I approach it by saying diffractive trifocal lens until proven otherwise, because that's the only technology we have that's going to monocularly be able to get somebody seeing both far away and up close, all the way across the deep focus curve. But we know that when you split light in patients who have macular pathology, corneal pathology, optic neuropathy, they simply just don't work as well. And you want to make sure that all of the light can enter into that lens focused. So if you have an irregular cornea, the light by the time it gets into the lens is going to be unfocused. And then you want to make sure that the photoreceptors are able to receive it properly. So if the photoreceptors are stressed in any way, I tend away from light splitting technology.
Right. But one of the catches, though, we can have a patient now that we do surgery on who's 65, everything looks pretty pristine. And 10 years later, they've got macular degeneration or glaucoma, and they really couldn't have predicted ahead of time.
It's very true. I think about this concept a lot. And for this exact reason, by the way, there's a lot of talk amongst ophthalmologists where we talk about make sure that the ocular surface is pristine before the surgery. And this is what Dr. Starr talks about a lot too. And I really think it's true. But I always wonder if we spend so much time making the ocular surface pristine so that we can rule in a candidate for a trifocal, that patient's likely to regress in their ocular surface disease. And then they're right back to where they were for their preoperative consultation. So patients with dry eye, like really notable dry eye that you would need to rehabilitate before surgery, I exclude them too, because I think they will recur. And I think your point is well taken about how do you predict who's going to go on to develop AMD, a little membrane, macular pucker. You really can't. And it is a risk that we have to take. And we, of course, have to take into consideration the age, health status of that patient. And most people who go on to develop macular degeneration, at least my understanding is by the time they're 65, they're probably going to have at least some drusen show up.
Right. Everyone gets older. You can't avoid that. I mean, things change. Even look at the corneas. When you go from age 60 to age 80, everyone's going to develop a little more against the rule still. You're not going to stay perfectly where you are today.
Totally true.
Now, with that in mind, how do you address post-op refractive issues? So, we're pretty good with lens calcs, but even with the newer AI lens calcs like we've done before, the best you can get is somewhere in the low 90 percentile accuracy. So how do you deal with the ones that don't hit that target?
I always tell the patients preoperatively that at best, and I undersell this a little, I say at best with our current formulas, we're about 83% accurate at getting within a half diopter of your target. But that means that if you have a little leftover refractive error, which most patients do have some, you might need a small pair of glasses, and I call them task-related glasses. So I preempt the conversation by not promising them 20/20 out the gate. I tell them my goal is to get you functional at the distances that you require. We can never get rid of the entirety of your prescription, although we try to do our best to get as close as possible, but there is still a chance that you could need some task-related glasses. For patients who are not satisfied with that answer and they say, I need 20/20 vision, that is another cue for me to say, let's do a light adjustable lens. For those who are less scrutinizing and for whatever reason we miss the target, whether it's an effective lens position thing or some sill that just pops up out of nowhere, I do include in my package a LASIK fine tune if needed. I
Okay, that
don't
makes sense.
I don't do it very often, but I certainly do it if needed and if it's a true miss on my end. I'm also, frankly, in my hands, and if it were my eye with my own hands, I feel like sometimes a lower risk option for patients who have a refractive miss that's somewhat substantial or and could be corrected with a lens, just doing a lens exchange. If it's enough of a miss, going in, swapping out the lens and putting in a new one, sometimes I feel is a safer option to not predispose them to long-term potential post-LASIK issues. Although I do LASIK and it's a wonderful procedure, it's not risk-free. It is also something we tend to try and avoid in our dry eye patients because of the risk of dry eye, and our older cataract patients tend to have dry eye, so I don't love that in them. So there are considerations there where I do sometimes just do a lens exchange.
That makes a lot of sense. So yeah, plenty of options now for patients. I'm glad we have this full spectrum. I'm always welcoming of any new technologies, any new IOL designs that are coming on down the road. We can offer all of these. But I want to thank you for spending the time here talking about this. Some important food for thought.
Well, thank you so much for having me on this podcast. It's been a joy to talk to you, and I wish you all the best.
Thanks again to Dr. Christopher Starr and Dr. Brian Schaefer for joining, and thank you for tuning in. For more insights on refractive cataract surgery from the October issue of CRST, visit crstoday.com.
For more shows like the one you just listened to, check out the podcast channel on itube.net.